Good morning, Barb. Good morning, Bart. Today we're not going to have a PowerPoint presentation. We're going to talk a little bit about a new article that just came out in the New England Journal of Medicine. It's about comparing the outcomes for CABG and CABG, that means bypass graft, for PCI. And PCI means percutaneous, it means stent, going in and putting a stent in. Before we do, just a couple of comments. We've got the Louisville event coming up day after tomorrow, Friday and Saturday. We're very excited about it. It's going to be 2 days of very deep, it's almost like, in some ways, like 2 days of listening to binge listening to videos, and that's a bit much for a lot of people. But here's the big draw to it. It's also attendees can get their labs, and most of them have already done that. Then bring their labs to the event, and we go out. We talk about specific lab interpretations. So now you're hearing about this stuff while you've got your own information in front of you. In addition, we have the CIMT. So we'll have the CIMT available as well. So it's a great way to get it all done at once and get a much deeper dive. Now, I was talking with Chuck Smith earlier today. Chuck Smith is going to be doing a, well, I'll go back to this. Chuck Smith is going to be doing a presentation at it. You may recognize the name. He told his story on the video, Wild Ride. Chuck realized he was having some cardiovascular risks. He's a businessman in Florida, runs a high-tech business called Guardian Manufacturing. They do, here's what I keep remembering. They fix rides like the Harry Potter ride, or other similar rides that shake people up, and you have to make sure that there's a technical connection between what they see visually and what they're feeling. But he does a lot of work in a lot of other areas. He does a lot of automotive work in terms of some of the high-tech equipment for automotive industry. He also does a lot of work with ozone. Ozone is a great way to sterilize and preserve fruits and vegetables without getting into the problems with antibiotics and things like that. Anyhow, Chuck began to see, he got the book by Caldwell Esselstyn, started following that, actually became a patient of Dr. Esselstyn's, and continued to try to cut those oils out of his diet. He did. On vegan diet, he lost, I don't know if it's 30 pounds or 50 pounds, a lot of weight. A few weeks later, he was at the gym. He had a workout, and on the way home, he started to have chest pain. He knew what it was. He drove a Tesla. He let the Tesla drive him to the hospital while he leaned into the back seat to get, was looking for his nitrates. So again, wild ride to the hospital during an event. But you got to go back and ask the question, why on earth would he have an event after losing 30 pounds? And here's what happened. He started looking at a couple of channels, and I hear this over and over from new patients. My channel and Ivor Cummins, the Fat Emperor. And both talk a lot about insulin and resistance and diabetes. Chuck started looking then and found out his triglyceride over HDL was 5. And here's the problem. For those of us that have trouble metabolizing carbs, it's very difficult to go on a low-fat diet. It's difficult or even impossible to go on a low-fat diet and get enough calories, but still manage your carbs, because you've only got 3 macronutrients. You've got protein, you've got fats, and you've got carbs. Now, so many folks that talk about low-fat diets, yes, I'm absolutely sure that the low-fat diets have saved a lot of lives. Because if you're eating your typical American diet, SAD, standard American diet, you're getting tons of fats, tons of carbs, and protein. Now, here's one of the things that we know. The most dangerous combination is a lot of fat and a lot of carbs at the same time. The carbs stimulate your insulin. Insulin shuts down fat burning. And so, that's why you just keep adding the fat on. But if you cannot metabolize carbs, then it's very dangerous to rely on carbs as your major source of fuel. And that was exactly what Chuck was doing on his low-fat diet. So he changed diets, went low carb, continued to lose weight, looks great, and has been doing very well. He's going to be speaking and sharing his experiences at the event. He's also going to talk a little bit about challenges in terms of encouraging other people to get involved with this. It's sort of like being on an airplane, flying into DC, let's say. You look down, you see the Potomac, then all of a sudden the plane lurches. You look out the window, you see one of the engines is smoking out, just like Sully and the crowd when they had that problem with the birds hitting the engine and wiping it out. You hear the emergency communications coming on the airplane, and they're saying, go ahead, get your oxygen mask on first, and then help somebody else. And you start to think about, well, I don't know why that engine went out. I don't know why we're doing oxygen so low. But then you forget all that. You get the oxygen on. You look at the person next to you, and they're stuck on looking out the window. They're not getting their oxygen on. You're trying to help them, and they don't want to be helped. And sure enough, Chuck has gotten CIMTs, paid for CIMTs for a lot of family members, a lot of coworkers, and seeing a lot of significant challenges there. But like many of us, you can find somebody that needs help. They'll typically, the dentists have this problem as well. They'll typically then go to their doc, and the doc will say, I don't know what CIMT, it can't be right. This is your labs, your cholesterol levels are fine. So we're going to have some discussion at the event this weekend about how to, I hate to say use the term, but how to be an evangelist for helping people learn to take this health information seriously, how to take prevention seriously, and prevent that heart attack rather than suffer a heart attack and then hope the doc's going to be able to treat you. That is not the right solution. So again, we've got a lot of interesting stuff coming up. We've got a couple of other events coming up. David Mintz is going to be having a CIMT access event. I think it's in San Antonio. That one may be in February. We'll put a schedule out. Clyde, if you would, please remind me that we need to do that. David's also going to be in Detroit. And we'll put that schedule out. We have the email addresses for all of you that have signed up at cardiorisk.us/forward. And Clyde, if you could go back on mute. We'll send that information out. We also have a couple of other events coming up where it's not only just a CIMT. You can get a CIMT, but you can also go ahead and get an evaluation as well. Pardon the digression and pardon me for clearing my throat. Those of you who have seen a lot of my videos know that I have a problem. A lot of people thought it was psychological overlay. I will admit there may be some there, but I got a sore throat about 2 weeks ago. My upper respiratory system is similar to my mother's. We get one of those things, and it's like an asthmatic getting a cold in their chest. We have problems for weeks. A lot of inflammation in our upper respiratory areas. Anyway, back to the point. There are going to be a couple of other events coming up. One in Orlando, looks like it's going to be February. time frame. Actually, we may have two in Orlando during a February time frame. One of them may be a joint event with Chuck Smith that I just told you the story about his wild ride in his Tesla. Another one to be announced. We also have another one coming up with a fellow named Mark Bentley. He's a dentist, and we're doing an event for the Western Ohio Dental Society. Both of those events are scheduled to be a one-day event. One of the things we're realizing is it helps patients sometimes, or people sometimes, to think about, I don't want to listen to this for 2 days. That's just way too much. But maybe one day is a little bit more practical, and we're going to try that, see how that goes. We've already got a lot of signups for the Ohio event. In fact, we have opened it up to YouTubers and others who want to come from the public. Now, let's get back to PCI and CABG, or stent and bypass. So here's what this article from the New England Journal this week says. They took a look at 5-year outcomes for stent or bypass for the left main coronary disease. Now, first of all, let's ask the question, why are we talking about left main disease? Because we're talking about the number one, the most common place that you get it. Number two, we're talking about a single vessel disease. Here's what's important about that piece. If you have a single lesion, it's much more amenable to a stent. You have to start thinking about more of a bypass when you've got 3 vessel involvement and you've got multiple places in the multiple plaque areas in multiple vessels. I mean, you just can't do that with, you can, but you end up with, you end up putting enough stents in, you end up with what some people sarcastically call a full metal jacket. Now, here's the next thing. Let's basically go simply down to the conclusions. In patients with left main coronary artery disease of low or intermediate anatomical complexity, in other words, as single vessel disease, not a whole lot of separate plaques. There was no significant difference between stent and bypass with respect to the rate of the composite outcome of death, stroke, or myocardial infarction at 5 years. I want to focus for a second on the last part of that statement. With respect to the outcome that they're talking about here is death, stroke, or myocardial infarction. I'm not in great shape to talk straight for 2 days, am I? Now, what I get, and I've got a lot of these comments, and I actually have, I saw a patient yesterday. He's a great patient, very disciplined, doing all the right stuff. And he said, Doc, you know, I heard you on another video say stents don't work. I have to tell you, mine worked. And I came, you know, I gave the standard statement that, look, I'm just talking about the results of the studies. And that was, for example, the COURAGE trial. This was the effect of stents in patients with stable ischemic disease. What we're talking about in both of these, we're not talking about improvement of symptoms. As you can see, the outcome is death, stroke, or myocardial infarction. So you bringing this up, and I appreciate your perspective on it. And you know what, maybe I can do some clarification on in the future as I describe this. When you look at the studies, they're mostly talking about outcomes. Are you going to have another heart attack? They're talking about, is it going to prevent you having another heart attack? And again, as we saw in the COURAGE trial and in several others, the answer is no. This thing this week makes a good point about comparison of bypass graft with stents. But let's go back to that outcomes again. As you notice, there's nothing in the statement about outcomes regarding symptoms. And like my patient said yesterday, I had really bad symptoms. I had pain. Anytime I started to get more than a walk, I started sweating. I just couldn't get beyond a walk. Now I'm doing high intensity intervals. So it's made a very positive impact on my life. So again, wanting to bring out and tease out the distinction between preventing another heart attack and or death or stroke versus symptoms. So these are the studies. They're talking about preventing another heart attack or stroke or death, and instrumentation doesn't do that. You know, that sounds confusing, and I tried to come up with an analogy. I'll give you the analogy, and hopefully this helps. Imagine you've got a break in your plumbing from the main line out at the street. It's coming under your your yard, and then it comes into the house. But in that break under your yard, you're getting a lot of dirt into your pipes. You keep having problems with your plumbing inside the house. So if you fix the plumbing inside the house, it's clearly going to fix the current symptom that you're having with maybe the commode not working, the shower not working, the sink not working, whatever. But it's not going to change long term until you go out and you fix the original or root cause problem, and that's getting dirt into the system from the very beginning, from the first part. So think of these procedures like bypass and stents, like fixing the plumbing inside the house that's already been damaged. These can have a positive impact, but they're not going to change the significant long-term outcome until you stop getting dirt in your pipes. So same thing with lifestyle versus procedures. Procedures may help the plumbing right now. They're not going to decrease there's no evidence yet that they're going to change your long-term outcomes. So I hope that's been helpful. We'll go ahead and take some comments now. Now I've got this thing. Oh gosh. Technology is wonderful till it doesn't work. And the problem is I usually don't know how to make it. Here we go. Okay. Thomas Gronek, good morning, Dr. Brewer. Is it possible to mitigate arthritic damage or even possibly reverse it on a carnivore diet with supplements? And if so, which supplements? I'm not going to be a great expert on changing arthritic inflammation with the carnivore diet. However, I will say a few things. The inflammatory diseases, we have inflammatory arthritis, or arthritis, that's arthritis is the plural of arthritis. Rheumatoid arthritis, psoriatic arthritis, and psoriatic basically is coming from the word psoriasis. Inflammatory diseases of the gut, like inflammatory bowel disease. One of the most common that people that don't link with this is Hashimoto's, thyroiditis. All of these tend to be inflammatory diseases. For the one other I'll mention is, yes, gluten and leaky gut is real. And there's a fellow named Alessio Fasano at Harvard who has done an incredible amount of work on this, and he's shown that yes, glutens, gliadins, or gliadins as some people call them, actually cause our tight junctions in our gut to dissociate, and that allows junk to come in from from the food that we're eating that's in the gut and come into the bloodstream and cause gut-related problems. That problem is found mostly in people who have heptoglobin 2. I'm not going to go down that digression. There's I've got a whole series of heptoglobin videos. Go take a look at those. But we do find people that have heptoglobin 2 genetic variation tend to have leaky gut. They have thyroiditis. They tend to have the other inflammatory diseases. So when you consider that, so back to your original question, Thomas, yeah, when you consider that this is an inflammatory disease, that one of the more common inflammagens, something that spurs inflammation, one of the most common inflammagens is glutens and gliadins. Once you cut that out of the diet, it does tend to have a very positive impact. I see that with my patients as well. Cutting, and it goes right along with cutting carbs. You know, the major source of carbs are grains, and the major source of glutens and gliadins are grains. You cut that out, you get a positive impact in both spots. I'm not going to deal with the supplement. I'm going to go to another question. 147 degrees west. How are you doing? I hope things are well in Alaska. I hope the weather's good. Hey, doc, try some matcha for that upper respiratory thing. I didn't get a lot of good from matcha, but maybe I didn't try it enough. Even a cheap grade of culinary matcha might help over the long run. Well, that's a good point. I didn't do a high grade matcha. But thank you very much for the suggestion. Part of I will say this, and you always start sounding worse when you start feeling better. And I'm really clear this stuff is loosening up at this point. Paul Gagne. Paul, you never did confirm if I'm pronouncing your last name correctly. If you did, I don't remember it. I hope I am. It looks French to me. Good morning, Dr. Ford. I'm healing up, low carb, 5'5" and 150 pounds, down from max 205 pounds. Well, you've obviously just taken a whole bunch. To go back to the genealogy of dirt in your pipes, you've taken out a whole bunch of the original metabolic challenges that you were causing your pipes, your arteries, when you were at 201 pounds. Congratulations on getting that done. Great advice, sir. But I found bone broth, homemade, boosts healing, especially immune diseases. You know, it's so frustrating. I keep wanting to do a video or two or a series on bone broth. I use it all the time. It's wonderful. I think bone broth is really good. My problem with not getting that series out is that we've got so much focus, so much need and growing response and need to focus on some of the more actual medical related stuff. I just keep focusing on stents and bypasses and where they work, where they don't, and medications and some of the other things we talked about, genetics and things like that. Oh gosh, this thing just moved again. 1, 2, 3, 4 contractor. I'm on mostly carnivore keto after 20 years as a vegetarian. Will I have issues with the saturated fats? I will tell you this. Actually, I just read a book by Nina Teicholz. I already knew some things about the big fat lie, and actually have a series called The Big Fat Lie. It's talking about Ansel Keys. 1, 2, 3, 4 contractor. If you're doing this, I'm assuming you know who Ansel Keys is, and that whole progression from low carb to low fat to low carb. Anyhow, the book by Nina Teicholz is called The Big Fat Surprise. It's a big, long book, but if you're into big, long books about fat, I would recommend it. She's a reporter and she's done a really good job with it. Bottom line, I would say that I'm not seeing a whole lot of people having a whole lot of problems when they switch from other diets to a keto or even a carnivore diet. I've got several patients now on carnivore. Mike Upshaw, good morning, Dr. Brewer. Oh, and I'll mention one other person. I don't know if you've noticed this. He's another YouTuber, doc. Oh, dang, I shouldn't have started that because I'm having a senior moment trying to remember his name. He's the one that just went keto. I saw a picture of him on a thumbnail, and he's continuing to lose weight. Actually, he didn't go keto. He went keto a few years ago, lost like what, at least 50 pounds, and has now gone carnivore, and he's continued to lose more. You could tell by looking at him that he did have the room, and he's looking better and better and better. So Bjorn to fly. Oh, Chow CEO. I have Hashimoto's thyroiditis. Does it contribute to inflammation, and what can I do about it? It doesn't. It's not so much that it contributes to inflammation. It's an outcome of inflammation. So what I would do about it if I had Hashimoto's, I'd probably go ahead and get the heptoglobin 2 gene study. You can get that. I've had patients get that on 23andMe, and using 23andMe and SNPedia, SNPedia. It's a public, it's like Wikipedia, and it helps you understand what you actually found when you got your 23andMe. If you have inflammation, then you've got increased risk for heart attack and stroke, significant increase. You've got increase for other things as well. And most people with Hashimoto's have these kind of problems. So I would go ahead, that's why I would go ahead and get that test. We can help if you have a struggle trying to get that that done. Thomas Gronick, thank you. Bjorn to fly. Did you see the TRIM study where for the first time epigenetic aging was reversed? Do you think the results are real, and will it also help for cardiac diseases? You know what? I think I did see the headlines on it, and I don't think I've got a chance to go back and review it. There's a lot of work going on in epigenetics. I will tell you, I'm going to be talking about epigenetics just a little bit in the upcoming event, and redid some of my deck on it. We first began to discover genetics back in the 90s. And one of the things you have to remember about genetics is this: the genetics, the old saying, genetics loads the gun, but lifestyle pulls the trigger. The connection between lifestyle and pulling that trigger genetically is epigenetics. I've got several videos on this. You look up my name, YouTube, and epigenetics, or look up my name, YouTube, and methylome. Methylome, M-E-T-H-Y-L-O-M-E. And here's what the methylome is. If you look at genetics, it's not just an issue. We've got what, 6 billion base pairs in there, every cell. So you're the librarian for all of that genetic information. How do you go in and find it? And that's exactly what happens. You know, I didn't develop insulin resistance until my late 50s. I didn't change my genetics, but my epigenetics changed. I've got a couple of significant risks. I was born a 10.5-pound baby. When I was born, that was a fat, happy baby. Now we know babies born at 8.5 pounds and more have significant risk for developing insulin resistance and type 2 diabetes when they're getting older. I also have 4Q25 and a couple of other things. But let's go back to that. So what we're finding, also my dad was 350 pounds when I was conceived. What would that have to do? It doesn't have anything to do with my genetics exactly. But again, both of those events, being born at 10.5 pounds and having a dad that was very heavy, there's evidence piling up that both of those changed my epigenetics. Now, back to the methylome. The way this librarian for the genetic system works is by methylating certain base pairs. Once he or she, once the librarian methylates some of these base pairs, they know they make it easier or harder to go back and find that specific base pair, and that base pair is located and related to genes. So for me, for example, genes that help my muscle cells and liver cells be responsive to insulin. They're just not as responsive as they used to be. Actually, I will say this, pardon all of these are digressions, pardon this digression, but I wish I had my results out here. I had an OGTT a couple of weeks ago, and it wasn't normal, but it was almost normal for the first time in years. Now, how did I do that? 3 changes, and I just want to make people aware of these. I have had these discussions with many of my patients who fit in this category, where you're older, you've gotten insulin resistant, but like me, you know, you're at a BMI of 20 to 22, and yet you could still lose a little bit more weight, but that's probably not going to move the needle that much, and you got everything else going on. There is a medication, it's called pioglitazone. I did start taking that. It used to be called Actos. Like any prescription medication, it's got its downsides, but I do think that Actos has made a very positive impact on my insulin sensitivity. That's what it was always known for. Now, I made a couple of other changes as well. I greatly increased my resistance training. And I am increasing my muscle mass. I'm no Arnold Schwarzenegger, but I've got a lot of room to grow in that area. But I have significantly increased my muscle mass. That can help because muscle mass improves OGTT. My sleep has improved, a couple of things like that. So you don't know, I'm like most of us, I'm an N of 1 in terms of the experiment, but I suspect, given all of the things that I know, that it was probably the pioglitazone or Actos. Okay, Thomas Gronick, thanks. Mike Upshaw, what's the maximum daily amount of carbs that a person should shoot for? Well, it depends on your goals. You know, if you're young and healthy and don't have any of these problems and you really don't care about carbs, you can eat a whole lot of them. I personally tend to shoot for around 100 grams per day or less. I know some people that are in the that are 50 and less, and I know some people that are significantly less than that at 30 or less. Paul Gagne. Oh, I did. Okay, thank you, Paul. Thank you very much. I did pronounce Gagne correctly. And darn, I moved this thing so I can read it. And oh, okay, Clyde's, I don't know if you can see the other comments. Clyde put down a couple of comments regarding the specific dates. David Mintz is going to be in San Antonio, February 15th, and in Detroit on April 4th. So a couple of upcoming dates. That's for the CIMT tour. Dr. Kimberly Lane, wow, the large baby data I'd never heard of. 9.5 pounds here. Well, thank you, Dr. Lane. And yeah, at 9.5, you've got some increased risk. You obviously don't have as much increased risk as I did, but you have some. Speaking, I don't want to make all of this all about me, but speaking of those risks, I was talking with my sister a few years ago when I had first shared with her that I had atrial fib. And I have both atrial fib genes, 4q25, and I'm homozygous 4q25, meaning I got an atrial fib risk gene from my mom, an atrial fib risk gene from my dad, which we didn't know about until fairly recently. The other thing that we didn't know until fairly recently was that long distance, high intensity workouts can increase your risk for atrial fib. And I did a lot of that. I've run several marathons and ultrathon, and I used to play 2 hours of full court football, baseball, basketball twice a week. So I've got my weekend warrior stuff in, and yet I have atrial fib. My sister was saying, Ford, why are you so sick? You know, you've got this diabetes, you've got atrial fib, the rest of the family's fine. Well, my answer for her was, because I looked. And that's one of the things I think most of you may understand on the channel, the vast majority of people that have the atrial fib at the level that I have, or the insulin resistance at the level I have, as in 95% or more, have it and have no clue. So that's part of the the goal of this channel, is to make people aware of risks and what you need to be looking for and how you can manage those risks. Old Alabama Gardener, good to see you, OAG. Micah and for those of you who haven't seen it, tune into Old Alabama Gardener. He's like the original farm to table, but his farm to his table. Mike Upshaw, whatever it takes to maintain your weight at the level you want. Exactly right. Clyde Castaneda, oh, another one, CIMT and on May 2nd in Memphis. I think from the way this system is looking, like we're getting to the end of the questions. If we don't get any other questions soon, I'll go ahead and wrap it up and we'll have a short one today. Angelus ad tenebris. I wonder what that means. Angelus ad tenebris. I think upcoming drugs like Lagendrol will help you with your muscle and bone density. Well, thank you for that comment. Let me just make sure that we've, Terry Wyatt, good morning. My glucose during 3 to 4 day fast doesn't start coming down until about day 3, less than 100. Where is it coming from on days 1 and 2? And is this some proof of IR? It makes me suspect IR, but I need to know some other things, Terry, like what your overall BMI is. In other words, what is your fat mass? The higher that is, the more you can have of this, but usually the more you have of that, again, is being driven by insulin resistance and starting off with higher numbers. If it's taking you 3 and 4 days to get down below 100, you need to take a deeper look at this. Another question I would have is, what is your full cycle during the day? Are you using continuous glucose monitoring, or are you just doing occasional finger sticks? Because it's very important to find out if you're over 100 between the hours of midnight, and 8 a.m., then that's also a problem. You should be dipping. Most of us tend to dip then. Then our cortisol kicks off sometime in the dawn, and we get an increase as our body's preparing to head into the day. Richard Lund, good to hear from you, Richard. I will let you know I had a couple of significant problems with my camera. My new friend Michael at Laura's Lean pointed out a couple of very interesting things, like I had it stuck on auto zoom. Thought you might be interested. Richard's done a lot of work. He's got a production background and did a lot of work helping me get set up and moving me from the old shaky paper days to the production that we have now. So Richard says, I plan a video on making bone broth with 4 Chinese herbs and chicken in the Instant Pot. Sounds really good. I got an Instant Pot based on what I saw in Old Alabama Gardener's channel, and am gearing up to using that. I got a pork shoulder the other day, and it was really fast, really easy. So James Cantor, good to hear from you, James. My blood sugar can me losing after a meal. Not sure what that sentence means. Then be higher fasting blood sugar in the morning. Oh, it can be lower after evening meal, and then be higher after fasting blood, then higher fasting blood sugar. So I think what you're describing, James, is the and I think, well, I thought you might have shared that you have a significant problem with your blood sugar before on one of the comments. So I think what you're talking about, and the question that may be implied in those statements is this: why would you eat an evening meal? Your blood sugar does its little peak, and then it dips down, but then it comes back higher the next morning. How does it get higher? And if that's what you're asking, then that's again due to cortisol. Cortisol is like it's a hormone made by the adrenal glands. The adrenal glands also make epinephrine or adrenaline. That's why adrenaline. And if you may remember, adrenaline or epinephrine are the fight or flight drug. You know, it's where you get really excited. Your body, your blood sugar goes up. Your body goes ready to go into fight. Cortisol is more of a long-acting version, or it's a hormone that has a long-acting adrenaline type of effect. It gets you ready for stress. And we typically have what we call a diurnal or a circadian change in our cortisol, with it beginning to peak early in the morning. That leads to what diabetics call the dawn effect. DAWN. At the dawn of the day, some people have a significant increase in blood sugar. Now, how does that happen? Cortisol is peaking. One of the impacts that cortisol has is that it tells the liver, okay, go in and find those glycogen, take the glycogen molecules that you have. And you remember what glycogen is. Glycogen is just long strings of sugar, glucose, attached one after another after another. And all it takes is a couple of seconds for the liver to shave off a bunch of those glycogen, glucose, the term is moieties, glucose molecules, and you can flood your blood with sugar. It was stored in your liver as glycogen. So yes, James, you did share. I thought I started to say that because I thought that you had, but thank you for sharing. Yes, James has diabetes and has shared that a couple of times. And I think that answered your question. If it didn't, let me know. DJ Kessler, you mentioned being a large baby, and for us and its influences. What about preemie babies? I was 2 months premature and weighed 2 pounds, 11 ounces. Well, you know, as you probably know, DJ, preemie as a whole has a lot of health risks. It's a whole different kettle of fish, though. The biggest immediate concern is whether or not you've developed your the surfactant in your lungs well enough. I'm so sorry, guys. Well enough to be able to breathe effectively. Once you get beyond that, you can have some scarring and some, like you've mentioned, you can have retrolental fibroplasia as well. 1957, Cato. How long should anybody do high intensity training? That is a great question. And for, you know, that's one of, here's the most common error that I see with high intensity training. Number one, that you don't do it at all. That's the most common. The second most common is, number two, that you do too much. The third most common is that when you do it, you do inadequate intensity and too long of an interval. People say, I'll go in and I'll do 5 minutes. 5 minutes is too long. If you're able to maintain that level of intensity for 5 minutes, it's not intense enough. You need to go back and limit the intense part of your cycle or your interval to anywhere from 90 seconds on down to like maybe 2 minutes, but preferably 90 seconds on down to about 30 seconds. There are professional cyclists who've done most of their training on 30-second intensity intervals. Now they'll get up to 10, 15, 20. I don't recommend getting beyond 10. And I don't recommend doing them more often than 3 days a week. I actually recommend them 2 days a week. So I hope that helps. With, I guess part of the other question is how much of a recovery interval in between, and that can be anywhere from 30 seconds to 90 seconds as well. Clyde Castaneda. Oh, Clyde is saying, OAG, you can reach out to Clyde at 859-721-1414. Clyde, one thing you may not know, you can go in and look at some of our videos. OAG has been a patient of ours. He put together a couple of videos on his channel. And we did a few videos on our channel with interviews for OAG. He is way out in the boonies in Alabama, got a wonderful farm there, which that's what his channel's all about. OAG used to be a rocket maintenance person, by the way. So he got some very, very interesting gardening videos. Anyway, we've done several videos together. He's a good friend as well as patient point. James Cantor, yes, it did. So this is normal. Bill Boswell, is it the dawn effect that causes me to wake up at 3 a.m.? Can this cause early awakening? I would tell you, Bill, I would say this. I've had a lot of patients, and it's happened to me too, where they noticed they were fasting. They wake up at 3 or 4 in the morning and they had very low blood sugars, like in the 50s, and even I did a couple of times in the 40s. If you're waking up at 3 a.m., one thing I would recommend is that you get CGM, continuous glucose monitoring. There are a couple of them that we've done, a couple of them that are out there. The Libre is made by Abbott. It's Freestyle Libre, and actually I have one right now. I can share one. Got a long sleeve shirt on. I'm not going to take that off, but it's a little button right here. You can't see that very well, can you? Sorry about that. But I'll check my glucose. Maybe it'll show up here. So here's the thing. If you're waking up at 3 a.m., yeah, I just had a meal about an hour ago and I'm at 101. I don't know if you can see that. And that's what you do. Now this Libre button has an 8-hour storage in it. So what can happen is you begin to find out exactly what your blood sugar was doing between 12 and 8 a.m. while you were asleep. And you're just not going to get that with finger sticks. I mentioned that there are 2 of them. The other one is Dexcom. Dexcom has just gone from Dexcom 5 to Dexcom 6. My friend and a great dentist in terms of oral systemic health, Doug Thompson, encouraged me recently to go ahead and do some more research using the Dexcom 6. He's got one. He loves it. I have one. I've done a couple of videos on it. I'm not even sure that they've come out yet. I didn't like it. It's supposed to be far more accurate than the Libre, and I don't have a real problem with Libre accuracy. And frankly, when I did the comparison, and a Dexcom on my belly. They were both remained accurate during the full 14 days. I did, here's the thing that really ticked me off more than anything else. The Dexcom is more complicated. It's got a transmitter, which you attach to your belly. And I don't like the belly because I kept feeling it. I never feel my Libre button. And in fact, quite often I forget that I've got it on. Like I haven't done that since last night. I forgot I had it on. With the Dexcom 5, I felt that in my belly all the time. I just didn't like it there. The other thing is, because you've got the 2 components to the Dexcom, you've got the transmitter and then you've got the sensor, which pops into the transmitter. I don't remember at this point what I did, but I think I took both of them off and threw them in the trash, just like I would a Libre. Well, that was $300 or $400 worth of sensor that I threw away. And it's because, you know, I don't like it. I spent a decade working at Toyota, and I've had that same focus then in automobile world. I always had it in the medical world either. I don't like passive engineering is a critical thing. In other words, engineer a product such that people cannot make mistakes. With the Dexcom, you have to remember, I take that transmitter off, I put it somewhere, I clean it up, sterilize it, whatever I'm going to do, and then I use it again. Or I just leave it on, and then I have to use the other sensors all at the same time, neither of which is a great solution for me. So I don't like the Dexcom as much as the Libre. The Dexcom is still far more expensive too. So now Doug loves the Dexcom. I know that Chuck Smith loves it as well. I like the good old fashioned cheap Libre. But if you're not doing either one, there's no way you're going to know what your blood sugar is doing while you're asleep. Bill Boswell, I hope that answered your question. One more, and then we're going to wrap it up, folks. Thank you very much for your interest. Eric Jantz, would you consider being metabolic flexible? Significant high calorie intake does not impact your weight over a medium period of time, a couple of months, equal to being insulin. Yeah, well, yeah, that's a good question. I'm not an expert in that area, but my first response when I've looked at that before is that, yeah, if you're able to burn any of the fuels, which makes a metabolic flexibility implies, then you clearly can't have significant insulin resistance. I mean, that's the definition of insulin resistance, is you cannot burn carbs very well. So again, sorry about all the coughing. As you can imagine, I'm very concerned about standing up for 6 hours a day for the next couple of days this weekend. So I apologize to you. And if you're coming to the event, I apologize even more so in advance. OAG, Clyde Castaneda, thank you. I'll call you. Okay. Talk to you guys later. Thanks for your interest. And now I need to figure out how to turn this off.